Alright, so the doctor went ahead and put an order in for extubation for Mr. James. So before we go in and do all that, we've got to get our equipment. So we're going to get our airway box, our bag mask valve, we need our manometer, we're going to need a nasal cannula, the bubble humidifier, 10 ml syringe, a yank hour, should be in the room already, and then a chucks pad. So we also need to have our suction set up to -100 to -120, so that we can go ahead and suction him. I'm going to wash my hands as I enter the room. Put my gloves on. Hey, Mr. James, I'm Taylor with Respiratory. The doctor put an order in to extubate because you did really good on those tests earlier. So we're going to see if we can get that sorted, okay? So I'm going to take a listen to his lungs. His vitals look good. His heart rate's 80. His oxygen's 94. Respiratory rate's 19. And his end tidal's 41. His blood pressure's 109/65. And his temperature's 37.5 Celsius, which is good. Happy with those numbers. So after we looked at that, I'm going to take a listen to his lungs. Cover him back up real quick. Alright, he does still sound a little junky, so we're just going to suction him one more time before we take that tube out. Alright. Alright, we're going to do that. And we're also going to test for the cuff leak. It needs to be greater than 15%. And then we can also look at the tidal volume on the ventilator. So I'm also going to check cuff pressure before we do the cuff leak, just so we can check to make sure that's all good too. So we just place this on the side. Ooh. Alright, and that's good. Alright, we'll put that away. And then we'll go ahead, deflate the cuff real quick, take a listen, make sure we hear the leak. Okay, and that sounds good. So we're just gonna put this air back in real quick before we get started. Alrighty. So we went down and suctioned him. We're gonna grab our yank hour and suction out his mouth real quick. Okay. I guess I'll leave this on because I'll have to suction his mouth again once we got the tube out. So I'm going to lay the chucks pad across his chest so that we don't get his sheets or gown soiled. I'm going to hook up his nasal cannula. We're going to set the nasal cannula to about 4 to 5 liters, just so that it matches the FiO2 that he was on as well before. And then we'll just lay this across here so that it's readily available once we need it. Okay. And then we also have our bag mask hooked up as well. And we'll have that back here. And we'll set that to 10 to 15 liters so that the bag's properly set for when we need it. Okay. All right, Mr. James, you ready to get that tube out? All right, I'm just gonna hook this up, okay? All right, so holding onto the tube, we're gonna make sure that we can get these ties off real quick. We'll just pull it through one side. still on there. Okay. All right. On the count of 3, I need you to take a big deep breath in, and I'm going to pull this tube, okay? All right, ready? 1, 2, 3. Big deep breath in. All right, cough, cough, cough. Keep coughing. All right. And we're going to put the nasal cannula on him. Move his ties. All righty. So we're just going to unhook that. Put the vent on standby. Wrap all of this up. And we do want to make sure that he is sitting at a 45-degree angle before we pull the tube. But I'm going to take another look at his vitals. Heart rate is 80. SpO2 is 96 on 4 liters. Respiratory rate's 21. His blood pressure is 109/66. And his temperature is still at 37.5. So those are good. We're happy with those numbers. I'm going to take another listen to him and take a listen to his throat as well. Make sure that we still have bilateral breath sounds and chest rise. And we're just checking the throat to make sure we don't hear any signs of stridor. But he sounds good. So I'm going to take off my gloves, throw all of my trash away, and chart the extubation time, what time we turned off the vent, and let the doctor know that everything went well. So at the end of my extubation video, I did forget to state my indication, which is going to be that the patient no longer needs it for his care going forward. Some risks from the extubation are going to be tracheal and vocal cord injury. Then we also have sinusitis and aspiration and hemoptysis, but we're going to monitor the patient very closely to make sure those things do not occur. And then we also have our complications, which is going to be an upper airway obstruction due to laryngospasm. It can also be laryngeal edema, which is stridor, or pulmonary edema. With the stridor, we're going to correct that. If it's mild, we can correct it with cool mist humidification. Moderate, we can do racemic epinephrine or corticosteroids. And then for severe stridor, it's going to be reintubations.